Hello, my name is Peter Kelly and I am a lecturer in mental health nursing at the School of Nursing and Midwifery in University College Cork. I'm also a member of the Ireland chapter of IntNSA, and I was a founding member and first president of our chapter from 2016 to 2018. I have met some of you before, others I haven't. But I'm delighted to get the opportunity to present in these rather strange times online. But I also look forward to kind of meeting up with everybody in future and hope that we will get the opportunity to do that. So today what I'm going to do is present some of the research and some of the preliminary findings, as our findings are still undergoing analysis, of a cross-sectional study of Irish community-based opiate substitution prescribing services. And first of all, I'm going to give you an overview of drug treatment and drug use in Ireland. I'm going to briefly describe the concepts of organizational readiness to change and innovation adoption, and talk about why they are important in terms of understanding how treatment works and why treatment works. I hope you will be convinced by the end of this presentation. I'll briefly discuss findings from a systematic review on ORC and innovation adoption, and we look at preliminary findings from the study which we've conducted here, and also, so what about why are these findings useful, or what potential do they have for further development in the Irish and international context. So if we look at Ireland, we have amongst the highest rates of opiate use, referred to as problem drug use here in the European Union. So we have a population of 4.8 million in Ireland, but we have up to 20,000 problem drug users, or people who are dependent on opiates. We have roughly 10,000 of those actively in treatment, and the estimates are that there are actually double that number in the country. Unfortunately, our drug-induced mortality rates are over 3 times the European average, which is not something to be proud of. And again, this research hopes to begin to edge things forward in terms of addressing that, and hopefully help to reduce drug-related deaths in this country. So I know I'm talking to a converted audience today. Most of us probably don't need to be sold the benefits of treatment, but just in brief, we know the treatment works. It reduces drug use, criminal activity, transmission of bloodborne viruses, and most importantly, reduces mortality. There's also significant economic benefits to the provision of treatment. And so even for the most hard-headed policymaker or financier in the government who doesn't have much compassion for people who use drugs, there's a study done from the UK in 2004 which indicates the savings are up as far as 18 to 1. So for every £1 they invested in the UK services, they did an estimate that there's an £18 return in terms of savings to criminal justice, etc. So whether that study is applicable to your country, I think it provides us with a good indication that the cost savings are significant. So we know the treatment works. We also know that some services are better than others at providing treatment, so they deliver better outcomes, but we don't know why. So a lot of this is attributed to the fact that much of our research is focused on categorical factors or disease states. So for example, we know that there's retention is a proxy outcome for success in treatment. The longer people stay in treatment, the better they do. We also know things like methadone dose are important, but we don't know what happens within a treatment service and how that, if you want to say you think about organizational dynamics or organizational functioning. And one of the more prolific researchers in the UK, Michael Gossip, described what happens in a treatment service as a black box. And he also suggested that it was very difficult to conceptualize. And I think that is true. So possibly one of the reasons why it hasn't received as much attention from researchers as it should is because of its complexity. We probably need longitudinal quasi-experimental, interventional type studies to really find out about treatment services, and those are expensive and resource heavy. There are easier ways to get published papers also. So I think this is sad but interesting. It's a report that was done in England in 2016. And I suppose I wanted to discuss this because it provides some context for the motivation for this particular study. So if I take it back to 2009, between 2009 and 2011, a group of IntNSA nurses who are now members of IntNSA and myself were knocking on the door of the Department of Health in the UK because of our concerns about changes that were happening to treatment services. And I'll explain about why those changes came about in a second, but we made the point to the Department of Health officials that the changes that were coming about because of government policy would result in an increase in drug-related deaths. And we also gave anecdotal examples of how service users are being affected by government policy. So when I say government policy, what the UK government did was they introduced the internal market to addiction treatment services. And that meant that long-standing NHS treatment prescribing services, so services that were part of the National Health Service and were staffed by typically by addiction psychiatrists, addiction trained specialist nurses, psychologists, some drug workers, also, and other healthcare professionals, had to compete against the voluntary sector, so against charities, to provide services on a 5-year cyclical basis. And initially, when that tendering process began, there was a cost-quality ratio which was balanced in favour of quality. So that meant that the NHS services generally tended to win contracts above the voluntary sector. But as the fiscal situation in the UK became more tight, the ratios of cost and quality were adjusted, and the voluntary sector started to win, if you like, more of the contracts. And the net result of that was that the services were nationally deprofessionalized. A lot of the experienced nurses and doctors, etc., left addiction services and went back into work in the mental health field. So then services were provided by the voluntary sector, which had different standards of governance, different levels of training of staff, and basically ran using a much less expensive model. So this report then, which was produced in 2016, it didn't say that a lot of the deaths were caused by this retendering process, although it did allude to that fact. Now, there might be some reasons behind that. Some of the reasons that were given were increases in heroin purity. We had an aging cohort of drug users, with the accompanying physical health challenges. That prescribing practices were influential, both in terms of prescribing drugs like gabapentin, but also in terms of prescribing methadone. Polydrug use, new psychoactive substances, alcohol use was a contributory factor. It did say that changes in treatment approaches had an influence on drug-related deaths. And it also acknowledged that treatment-related factors, such as access and retention in and to treatment, clinical governance and workforce competence, and the delivery of evidence-based treatment were solutions to addressing this issue of increased drug-related death. Now, I could argue that one of the reasons why the influence of changes in treatment provision was overlooked is because we don't have sufficient evidence that draws a causal relationship between treatment service configuration and service user outcomes. So, for example, if we look at studies that were done maybe by Linda Aiken or the RN Forecast around nursing, they looked at specific skill mixes, training levels of staff, and they have fairly good evidence now to say that there's a particular outcome we can expect, a patient outcome we can expect if we have particular configurations of staff. We don't have anything like that in substance misuse treatment. Now, my research is not going to accomplish that, or the research here that I present today, but I hope that it will in some way edge things forward and help us to understand how treatment works a little bit more effectively. So, looking at this problem, I did a literature review, looking at papers that looked at the hows and whys of why substance misuse treatment services work. And I came across a number of studies which have been conducted in the United States, which specifically looked at a concept called organizational readiness to change. And I'll talk about that in a little bit of detail later. It also transpired from the research that a lot of change efforts, so if you think about substance misuse service, that could mean the implementation of an naloxone protocol or the delivery of a new psychosocial intervention, that 30 to 90% of change or innovation efforts in healthcare organizations fail. So there's a high failure rate in general, in terms of delivering new treatments. And the organizational context in some way contributes to that. So Vicola here and Armanakis attributed this to an organization's inability to establish sufficient readiness. So what I also found was, as well as organizational readiness being related to an organization's ability to change, it also has been used or operationalized as an overall measure of organizational functioning, and has been related to aspects such as how effectively a service develops therapeutic relationships with clients, how effectively they engage them, etc., etc. So where did this come from? It comes from the field of organizational development, which concentrates on the human relations aspects of organizations. So some of you would be familiar with the Hawthorne experiments, the Hawthorne effect in research, which comes from experiments that were conducted by Kurt Lewin, where they began to realize that human relations have an influence on organizational productivity and organizational output. So this concept of ORC, effectively, it's multidimensional, but in a nutshell, it's a shared psychological construct within an organization, and basically it's how effectively or how willing and able the staff are collectively to support organizational change. But again, and I look at this later, it has been used as a measure of organizational functioning. And if I look at this tool, I hope this will become more clear. So in terms of how, so the theorists Wiener and Armanakis, who I've referenced in this presentation, talk a lot about the theoretical constructs of theoretical aspects, or the theory of organizational readiness. It's been operationalized in a number of different ways. So a review by Gagnon and colleagues looked at 26 instruments which operationalize organizational readiness to change. And they found that a tool developed by the Texas Christian University, which you can easily Google and find TCU forums. You can see a selection of very comprehensive forms they've developed for substance misuse services. But this tool had the best psychometric properties from the 26 tools they reviewed to measure knowledge transfer in healthcare settings. Now, luckily, this tool was developed to measure substance misuse services and was validated for that context. So I'll just talk about now how the concept of ORC is operationalized within this tool. So what you see in front of you here is 4 domains. We have motivation for change, which is effectively the drivers of change in an organization. And this is measured, all measured using a form, 120 item form that a staff member would complete as a quantitative questionnaire. Institutional resources then look at staff's perceptions of offices, staffing, training resources, etc. Organizational climate, our 3rd domain, looks at staff perceptions of the mission, clarity, team cohesion, how autonomous they feel in their role, how effective communication is in the organization, stress levels, and then how open their organization is to change. Finally, staff attributes looks at opportunities for growth, how the staff rate their own skills and professional abilities, so efficacy, the degree to which staff can influence what happens in the organization, and also their own views of adaptability. So that's just one way ORC was operationalized in the tool by Lehman Simpson and developed by Lehman Simpson and Joe. So that was of particular interest to us. So we conducted 2 systematic reviews on organizational readiness to change. And the first review looked at the relationship between organizational readiness to change and the process of innovation adoption. So we looked at innovation adoption as a process, as training exposure, an individual's decision to adopt the training, and then how sustained the use of that particular training was in practice. So it might not necessarily be training, it could be any organizational change. The second review, which I'm not going to talk about today, looked at the relationship between organizational readiness, ORC, and client outcomes. Hopefully I'll be able to present the results of that study to you next year. So what did the review find? Well, it found that ORC is very promising in terms of helping us to understand, ORC measurements are very promising in terms of helping us to understand how and why substance misuse treatment services work. So there's 14 papers included in this review. Most of the studies were cross-sectional. All of them used the same ORC tool developed by Lehman and colleagues. They looked at heterogeneous outcomes, none related clearly to one stage of the innovation adoption process. So it was quite complex in that respect, trying to determine what stage of the innovation adoption process each study related to. So what we found was organizational climate was the most significant domain in terms of causal relationships between staff perceptions of ORC and the organization's ability to adopt to new innovations. It was a strong predictor of support for evidence-based practice and predicted better client outcomes after training as well. Staff who viewed themselves, so if we look at the staff attributes domain, as having better attributes and skills, are more likely to support the process of innovation adoption and have greater preferences for evidence-based practice. Interestingly, services where there were more staff who saw themselves as having more influence were much more effective, if we look at multivariate analysis, much more effective at supporting the process of innovation adoption. So that's an interesting finding which might have a good translation for recruitment, policy development, etc. Expectedly, programs with higher needs, more specific training needs, and a greater desire for training were more poorly resourced and were less likely to be exposed to training and identified more barriers to implementation. And again, that might seem like common sense to people, but unfortunately, as I think most of us will know, Common sense is not that common, and when people are designing services, particularly for drug users, they don't tend to provide the resources that are required. And hopefully this will begin to underpin an argument for increasing resources for services. Internet access was of particular importance for exposure and adoption. That may be that services who had internet access were in general better resourced, but also remember that most of the studies here were conducted about 10-15 years ago, when there would have been staff would have had less access to things like smartphones, tablets, etc. So I'm not sure how relevant that is in today's context. We also found that studies measured ORC in conjunction with other variables. So services that had a research affiliation, so a connection to a university, a relationship with a university, were much better at implementing evidence-based practice and change. We also found that smaller to medium-sized programs were better at adopting to change. Unfortunately, the papers didn't specify numerically what a small, medium, and large service looked like, but it did tell us that the size of the program indicated, had a causal relationship with their ability to change. Urban treatment services tended to be better at adopting to change than rural treatment services, and unsurprisingly, the education levels of staff were important. So services who had staff who were more highly educated were better at adopting new innovations and change than services that had staff at lower levels of education. And overall, the sample size in a lot of these papers were quite big, up in the thousands in terms of numbers of treatment services and staff. So we could say with some confidence that a causal relationship had been established, but none of the papers looked at what to do or how to address deficits in organizations once you identify them. So for example, if your organization has poor communication, poor team cohesion, how do you actually address that once it's been identified? So hence the next study. So I'm not going to labor on this. This is a very word-heavy slide, but this is extracted from the paper, from the systematic review, and it basically summarizes the types of things that ORC was related to. So for example, here we have staff attributes, where people saw more opportunities for growth, they supported evidence-based practice, they had a higher commitment to change it, to engage in the change process. But visually, you'll see here, as I move into the next slide, that organizational climate was the most important domain in terms of predicting successful adoption to change. So here we have where the services had a clear mission statement, there was greater training satisfaction, more trial use of innovations, and so on and so forth. So I won't labor on that anymore. So effectively, this is a basic concept map of my PhD study. So as I said, we did 2 reviews, and I'm going to talk about one of those reviews today. So what we looked at was the relationship between ORC and innovation adoption and client engagement. And that was based on the findings of 2 systematic reviews. And I've only, as I said, only talked about one of those today. So again, this is a basic concept map of the study that we did subsequent to the review. So you'll see here we have the 4 ORC domains, and within the innovation adoption measurement, we measure training exposure, training satisfaction, training utilization at individual level, and training utilization at program level. I'm not going to talk about client engagement today because we don't have time, but I also interviewed 12 staff in Irish community treatment services about the organizations in general, and asked more specific questions around how effectively the organization had adopted change. And I'll talk about the results to that in a second. We also included some measures on burnout, which yielded some interesting results that I'll talk about at the end of the presentation of the quantitative results. So briefly, we looked at 12 services spread across a wide geographical area in Ireland. We got 132 staff to complete a questionnaire, which took approximately 20 to 25 minutes to complete. We found when we looked at the psychometric properties of the tool that had acceptable psychometric properties, but the subdomains of e-communication and office resources had low alpha values. And that was something that wasn't consistent with studies that were conducted in the United States and the UK. So we tried a couple of things in terms of taking out particular scales within that to see if it would affect the alpha values, and it didn't work. So for example, in office resource, it asked a question about group facilities, and not all the services that it would have looked at would have conducted groups. So we thought maybe initially that removing that item might change the alpha values, but it didn't have any impact. So that's just to make you aware of that. The mean scores were relatively consistent with those in previous studies. So just to give you an overview of the sample, we had project workers and general assistants 31%, counsellors 20%, nurse, medical, other professional and admin as well in that sample. Reflective of probably the Irish population, which has only become more multicultural in the last 15 years or so. The majority of staff that were interviewed were white Irish, so 95% white, and the rest Asian, Black African, Chinese, and people who identified as other. Overall, the cohort was quite experienced, with over 70% working 5 years in the field, 60% 5 years in the post, evenly split between male and female, quite an educated workforce, as in 86% were educated to degree level or above. But overall, the tool showed acceptable reliability in the Irish context. So first of all, we looked at the relationship between ORC and training exposure. So that also incorporated some demographic variables. So project workers and staff at lower education had less training exposure, which is arguably expected. But what it means is in real life is that staff who had the least levels of education were receiving the least levels of training in practice, whereas we could argue that it should be the other way around, that people who have less training need more training. So people who were longer in post got more exposure to training. When we did the bivariate analysis, there was quite a strong evidence of quite a strong causal relationship between the subdomains in ORC and training exposure. So without going into the specific subdomain, which takes a lot of time, I'll just give you an overview of the domains. So organizational climate was the most significant, followed by institutional resources, staff attributes, and motivation for change. And that was a pattern that we saw generally saw across some of the other results. In terms of the multivariate analysis, training resources expectedly, but also growth in the institutional resources domain, but also where staff saw themselves as having more opportunities for growth, they also saw themselves as, had more exposure to training, which I suppose is an expected result. Again, if we look at training satisfaction, bivariate analysis showed 13 out of 18 subdomains. Again, similar order of significance in terms of domains, but motivation for change didn't show any significance in this respect. Now, interestingly, people who had greater computer access in the institutional, greater training resources, and greater training access had higher training satisfaction. Sorry, I'll just go back to that. And an unexpected result was that efficacy, where staff saw themselves as having much better abilities, there was a negative correlation with training satisfaction. And that's a result worthy of further investigation. So one explanation for that might be that the quality of the training was considered to be poor, that staff who consider themselves to have higher skills or higher levels of abilities found the training less satisfying. So there may be some indication there that the training provided by the organization did not meet their needs. And I've included results on burnout here, but I am going to specifically talk about burnout separately at the end of this. So a decision for an individual to actually utilize the training in practice. Again, there was strong, with the bivariate analysis, we had 12 of 18 subdomains, again following a similar pattern with organizational climate being the most significant. Although I would stress that we had 4 subdomains each here, with the level of significance being higher within the organizational climate domain. Multivariate analysis then showed that where pressures for change were higher, there was lower training utilization. And the motivational for change domain tended to have a negative relationship with the adoption to change. So where there were high pressures for change, there was lower training utilization. Maybe not so expectedly, where there was, again, this replicates the result that we found in the US, which is interesting, where there was access to e-communication, so internet access, there was higher levels of training utilization. And again, in relation to organizational climate, where people had more opportunities for growth, greater influence, they utilized training more effectively. An unexplained result, and having spoken to the tool developers about this result, we still can't shed any light on it, other than there are so many variables involved in this particular study that you will get unexpected results. But it said that where services that had a clearer mission statement had lower training utilization, and I haven't been able to offer any explanation for that. Again, lower education levels were associated with lower training utilization. What was interesting here, and again, where the qualitative research maybe was more useful, is that counsellors have a higher utilization of training than project workers and medical staff and nursing staff. So the qualitative aspect showed us that counsellors were the only professional group that received regular supervision. So perhaps there's something about the provision of supervision for counsellors which makes them more effective at adopting new training, and maybe that opportunity to reflect on their practice provides that. So if we look at the training utilization service level, again, similar results with the bivariate analysis. There's indication of a relationship, possible causal relationship between ORC and service level utilization. Again, this negative relationship where there were high program needs, lower training utilization. So more poorly resourced programs didn't utilize training as effectively. And again, where staff saw themselves as being more influential, there was greater utilization of training. Again, lower stress, greater utilization of training. And one unexpected result, and again, the qualitative study maybe shed a little bit of light on this, the places that had higher team cohesion had lower training utilization. And one reason for this might be that there is, from the qualitative data, reportedly high cohesion between different professional groups, but actually cohesion between interdisciplinary cohesion is potentially a lot lower. And that's something that's worthy of further investigation. So for example, nurses work in one area of the building, project workers work in another area of the building, who might see themselves as being in a tight-knit team, but actually there isn't great cohesion between each section of the team. So that is one explanation for that result. And again, lower levels of education were key. Burnout was also seen as quite significant. I'm aware of time, so I'm not going to go through all of the results here. But basically, where burnout was higher, satisfaction with training was lower, and the utilization of training was lower. There were also significant differences between the lowest level of education had higher levels of burnout than staff at master's or PhD. And interestingly, nurses had the highest burnout levels compared to counsellors, other healthcare professionals, and medical staff. And potentially, again, the key ingredient there is the provision of supervision. Obviously, it's to do with workloads, but also the provision of supervision for counsellors and not for nurses. So finally, in relation to the results, if I want to look, this is a finger in the wind on the qualitative findings. What's been reported by all participants is that there's been seismic changes in Irish addiction treatment services in the last 10 years, which are not attributable to a single factor. So when I say changes, services have moved quite dramatically from an abstinence-based model to what people described as a more pragmatic harm minimization model, where abstinence is still a goal, it's on the menu, but it's not the only thing on offer to service users. So staff described before that the service users had to fit the service, whereas now they say the services fit the service user needs a lot more. And perhaps that's reflective of societal and cultural changes that occurred in Irish society and influenced that change process. So again, that's worthy of more investigation, and something that would not have been identified through the use of the ORC tool. Also, that there's no standard model of prescribing services. There's issues with structural issues and the oversight bodies, which are seen as mitigating or pushing against successful change implementation. Features of successful change implementation described by staff were resources, leadership, multi-level buy-in, follow-up and audit was seen as being particularly important, team meetings, and a service user focus. Supervision also may be important for the adoption of change and reduce burnout. And for most staff, meeting the needs of the service users was seen as a very significant change driver, and that came out quite a lot. So again, I spoke about cohesion already, how that's worthy of further investigation. And surprisingly, one of the changes that staff said they would like to see on a very regular basis was changes to physical infrastructure and buildings. And that might be because due to the closure of some of our old psychiatric hospitals, the drug treatment services have been housed in old psychiatric hospitals, which maybe some of which are not purpose-built for use for drug treatment services. But staff placed a very strong emphasis on the physical infrastructure, sending out a particular message to service users. So that was interesting. The so what then, and we're getting to the end of the presentation now. This study so far confirms the reliability and validity of this tool for the Irish context. It establishes that there is a relationship between organizational attributes and their ability to adapt potentially life-saving technologies, such as naloxone or, again, other interventions. It indicates some of what the ORC tool can and cannot capture, and I spoke about the big cultural shift over 10 years, significant changes like that over time. It identifies specific measures that can enhance innovation adoption. And again, that was something that was achieved which is hopefully going to be achieved through the qualitative study. So again, looking at specific measures which organizations have in place that can enhance that process. It also, through the qualitative piece, identifies target areas for organizational improvement and identifies several other areas, hopefully worthy of further investigation. I think I've mentioned some of those. So what next? And you might be glad to hear this is my last slide. The tool itself was developed in 2002 and hasn't received much refinement since. We need more robust, bigger studies to identify what factors influence ORC. So we need interventional studies, quasi-experimental, longitudinal, to look at the impact that, say, reduced communication might have on innovation adoption and client outcomes as well. We need more qualitative data to understand how and why ORC might be important, or this concept of organizational readiness might be important. And again, looking at the work of Linda Aitken, the RN forecast, I think substance misuse services really need a big, expensive study to look at the relationship between staff, skill mix, the economic cost, the economic benefits, so that we can plonk a piece of research in front of a minister for drugs in whichever country and say, look, if you staff the service in this way, etc., you get these outcomes. And at the moment, we don't have something like the RN forecast or the work on skill mix in hospitals by Linda Aitken. So that is it. I hope you enjoyed the presentation. I hope you are enthused about organizational readiness to change and its utility for substance misuse services. And I would like to thank you very much if you have listened to all of this presentation. So there's some references here. Please get in touch if you have any interest in any future collaborations, or if you have any questions about research or research findings. I would be very glad to share those with you. So goodbye and thank you.